Of the eJournal Club, and today we are reviewing this article on the effect of deep brain stimulation of the pedunculopontine nucleus, or what is also called PPN nucleus, on cognition in Parkinson's disease and progressive supranuclear palsy. This article again is submitted by my fellow Dr. Erin Smith. So all the content and summarization is attributable to her, and I will be adding some of my own comments outside of this article, but all the summarization of this article is from Dr. Smith, with due credit to her. So, why this article is significant? So, this article is reviewing the effects of deep brain stimulation, which is a technique where we put a pacemaker wire in the brain with 4 contacts or 8 contacts, and then stimulate it with a pacemaker like battery, but with the difference being that this battery has a far more control in changing the frequency, the amplitude of the stimulation, the pulse width, and so on and so forth. Deep brain stimulation surgery is established for treatment for Parkinson's disease. However, where you put the wire in the brain is different, and there are different targets that you can use. So you can use a subthalamic nucleus as a target, or globus pallidus interna as the target, GPI, and ventral intermediate nucleus, or VIM. These three are the approved targets by FDA for various indications. VIM for tremor, including essential tremor and Parkinson tremor, while STN and GPI are for Parkinson's disease. Now, this article is looking at a completely new target, which is still a research target called PPN, or pedunculopontine nucleus. And although this article is specifically looking on the effect of cognition after doing a PPN surgery of DBS, but this is an important target in itself to be aware of and be familiar with. Among many targets that are being used, this one is being used for Parkinson's disease specifically. So the good thing about this article is that this introduces the concept of PPN DBS stimulation. It is also a comprehensive neuropsychological assessment or cognitive assessment after PPN surgery for Parkinson's disease and PSP, and it includes the PSP patient, which is important and useful. However, the challenge is that this article has a very small sample size of 5 Parkinson's patient and 2 PSP patient. So it's not very generalizable. But PPN surgery in itself is very, very rare. You have to be aware that PPN, it's therapeutic. It's not an established target, and is very controversial. So it's hard to get patients who have had this PPN done, and especially get them in a way where you can do a comprehensive cognitive assessment before and after. The assessment done in the study is very comprehensive, as I will review this table later on that shows all the detailed comprehensive assessments that were done in this study. So the one thing to know about the PPN DBS is that this is a target that is being used to improve axial symptoms. So axial symptoms in Parkinson's disease will be symptoms that are not lateralized to a limb, upper limb or lower limb, but more central to the body. For example, speech, for example, swallowing problems, gait problems. All of these will be the central truncal symptoms, whether they be bulbar or whether they be in the hips or in the body itself. So these axial symptoms are very hard to treat. So for the one specific axial symptom that have been a biggest target for this PPN or need for this PPN surgery is the gait impairment, especially things like freezing of gait or postural instability that develops in Parkinson's patient. Those symptoms do not respond to the current targets. So subthalamic nucleus or globus pallidus interna, GPI and STN do not have any significant improvement on gait usually, although the exception is that if the patient has a response to levodopa or gait impairment, then they may improve with these surgeries. But in general, there are patients who have no levodopa response to these symptoms, and then the DBS will not help them. That led to use of PPN as our target. Before I explain PPN a little bit more, Let's look at the overview or abstract of this article. This was published in Clinical Parkinsonism and Related Journal. The Parkinsonism and Related Disorders Journal is a very long established journal, very well respected. But this is the Clinical Parkinsonism and Related Disorder, which is a new clinical journal by the same authors, and it's still pretty new, but the quality of research published in this journal is pretty good. So in abstract, the author summarized that that there has not been much look at the effect of PPN DBS placement on cognitive changes. And they basically summarized that they looked at 5 Parkinson's patients and 2 PPS patients, 2 PSP patients, progressive supranuclear palsy, who went in to have a PPN DBS, and they had a neuropsych testing done at baseline, at 1 month, and at 1 year. And then they summarized that overall there were minimal changes, but there was some decrease, especially in processing speed and verbal fluency, especially when switching category for verbal fluency, that did decline. And so overall, they're summarizing that it's generally very safe. However, there are some slight decline that are measurable even in these small number of patients, although the decline itself probably is not big, but is statistically significant in these patients. So coming back to PPN, PPN or Pedunculopontine Nucleus plays a role in locomotion, voluntary movement. It has cholinergic neurons, not dopaminergic neurons like the subthalamic, like the substantia nigra. So this is the cholinergic network, the network which is more for cognition and also for gait in PPN. And this nucleus also degenerates in patients with Parkinson's disease and PSP. And we think that it manifests as gait and postural impairment in these patients. Previously, when the studies were done on the MPTP primate model of Parkinson's disease, where the monkeys were given MPTP injection to develop damage in the brain consistent with Parkinson's disease, it showed that if you target the PPN in those animal models, then you can actually improve the akinesia or overall slowness of Parkinson's disease. And there were some studies that showed that if you pair the PPN with STN DBS, then you can have really good benefit on the patient. And then there have been some response of improving freezing, especially with unilateral PPN. And there has been some improvement in the score, as much as 33%. But overall, this is still not a fully established target because the results were mixed. And in one large study, or probably 2 large studies from multi-center, the overall average results were negative, or there was no significant improvement in patients with PPN DBS. However, in the post-hoc analysis, it seems like that some patients had no response at all or worsening, while there were few patients, probably a third or a half of the patients, had really, really good response that lasted for a long time. And there have been many presentations of these case reports of patients who had wonderful response. Even from the same center, some respond and some don't. And currently, there is no good understanding of what separates out those patients who will respond to a PPN DBS surgery. But the question here is that the PPN DBS, what effect it has on cognition. Now, it is important for 2 reasons. One reason, as I mentioned earlier, that this is a cholinergic neurons, which is the center. Cholinergic system is the main system for cognition, and that's why we try to increase the acetylcholine esterase. We increase the acetylcholine by inhibiting the esterase in disease like dementia or Alzheimer's disease. And also, it's important to remember that in the deep brain stimulation surgery done for other targets, for Parkinson's, STN and GPI, there is cognitive decline in those patients. So STN especially shows a clear problem with verbal fluency, which was also seen in this study as mentioned in abstract. But and overall, all GPI is considered to be safer than STN by most experts. In terms of cognitive decline, it was less noticeable when compared with STN, or not there. So for that reason, it was important to ask this question, that if other targets, established targets, can cause cognitive decline, does PPN does that too? If it does, doing it more or less? So the participants, so I'll jump to the table 1. The table 1 summarizes the participants in the study, the 7 patients. The first 5 are Parkinson's disease patients, and all of them are male. The PSP patients, 1 is male and 1 female, as you can see over here, and they have a long disease duration, as long as 21 for a Parkinson's patient, but 17 is also there, while for PSP patients, especially the female, it was only 2 years of disease duration. So disease duration is all over the place. The UPDRS testing scores are relatively mild in Parkinson's patient, surprisingly. So only score of 16 in a patient number 5, while higher scores are actually seen for PSP patient, scores going as high as 44 and 30, but still relatively mild scores. Operations were unilateral. Looks like only 1 patient had a right side DBS done. All the others had left side, or 1 patient had bilateral done. This was the low UPDRS score, 16 score of Parkinson's patients with bilateral surgery. MMSEs were good to begin with. Surprisingly, the lowest MMSE was 27 for the same patient having bilateral surgery, and 1 PSP patient have a MMSE of 27. Actually, the other PSP patient also had an MMSE of 30. So although MMSE is not a very good measure of cognitive weaknesses in patients with Parkinson's or PSP, but it still gives you an idea that they don't have any major cognitive decline as measured by MMSE. Something like MoCA or Montreal Cognitive Assessment would have been more sensitive in picking up problems, especially in PSP patient where the problem is cognitive, executive functioning and frontal kind of dysfunctions. So these patients went in to have surgery, and as I mentioned, they had a very extensive testing done. So table 2 basically lists all of these testing. You can see they had the dementia rating scale done, they had the National Adult Reading Test, Wechsler Abbreviated Scale of Intelligence, the California Verbal Learning Test, they had the Wechsler Adult Intelligence Scale, and then they had the Delhi-Kaplan Executive Functioning System testing done. A very detailed testing done on these patients before and after. You're seeing with the N that not all 7 patients had everything available, so you see a lot of these testing are on 6 of them, although the total score is available on the all 7 patients, and so on and so forth. But majority of the testing details are available on most patients. At least the total scores are available on all 7 patients. Now, before and after, and this is a comparison of before and 12 months after, although there was a testing done 1 month after, shows some clear changes. So let's focus on this column of p-value. The p-value is what will ascertain that the difference being seen is not just random, but has a very high likelihood of being actually significantly present, and not just because of a random variation from testing on another day or a year later. So as you guys know, arbitrarily it has been chosen by the field to have a p-value of 0.05 as being significant. So any number less than that is considered statistically significant. Any number higher than that means that there is too high of a chance of randomness. So 0.05 is about 1 in 20, 5%. So less than 5% chance of randomness is considered acceptable or statistically significant, and any chance more than that of randomness is considered a random answer, and it's an arbitrary selection, but that's something that we have to stick by. So 0.05, if we look at the values which are less than 0.05, we find out that there is a clear decline. 0.038 in patients having initiation and perseveration, initiation or perseveration. So in the dementia rating scale, patients dropped a score over there. Patient also had a lower score of 0.027 in total recall from trials 1 to 5, and 0.017 on color word interference or color naming test. It's a complicated name. It's also, this test is commonly also known as the Stroop Test, where you are seeing different color names written in different colors. So green may be written, but the color of the words themselves might be red. So you sometimes have to say the actual written word, which is easier to say, but a lot of time the Stroop Test is when you ask them to say the color that the word is written in, but not the word itself. So you have to say red, but not green. which makes it very hard. And this is kind of a frontal disinhibition test where you're looking at the frontal capacity of suppressing the first impulse of reading the word but actually saying the colorate. So it is clearly significantly low. And then verbal fluency is actually the worst and is very, very statistically highly significant of 0.09 and 0.01. This is the category switching verbal fluency, where you're creating words and then the categories are switched from one to the other category to see if you can keep making words or keep coming up with new words, such as names of animals and so on and so forth, or fruits and vegetables. So this is significantly impaired in these patients, noticeable. Although the numbers themselves are not too bad. You can see 8.57 was the score before, and 5.86 is the score after. So a drop of 2 points or so, or 2 to 3 points, 2.5 points of a change on this score. So what the authors summarize based on their assessment is that in this first small study looking at cognitive effect of PPN DBS in patients with Parkinson's disease and PSP, there is a decline in category fluency and processing speed. However, when you look at only Parkinson's patient, remember there are 2 of the patients are PSP, then the changes in the DRS performance, the initiation and perseveration, and the Stroop test was not significant. That still leaves the loss of verbal fluency as a finding significant even with Parkinson's patient alone. Remember, these are very small number that we're looking at, 5 Parkinson's patients and 2 PSP patients. But it's interesting that even in other targets like STN and GPI, the main impairment, especially in STN, is in verbal fluency, which is also what we're seeing with the PPN DBS. So there seems to be a common theme between all these deep brain stimulation surgeries in the brain. So this is the summary of the article. Again, our takeaway: this is a good, detailed, comprehensive assessment of cognition before and after. However, it's a very small sample size and it's hard to say what to make of it with that small sample size, but it's likely that the cognitive performance overall seems to be relatively preserved, especially with Parkinson's disease patient, except for that small change in verbal fluency, which is consistent with other DBS surgery targets like STN and is nothing new for PPN itself. Again, I would like to thank Dr. Erin Smith for submitting the summary of this article, and all the comments and additional points on this article were from me. This is the article that you can look up. It's in 2019 year publication, and these are the references that you can look up on the article. Thank you.